Um, Most of the patients will come to you with disc edema, but they will not have a diagnosis whether they have bilateral papilledema with vision loss, without CNS lesion, with CNS lesion. They will just come to you with signs. So you have to figure out what is the cause for this raised intracranial pressure, along with tumors, benign intracranial hypertension, as well as nowadays most of the patients get MRI rather than blood pressure checked. So I think it should be reversed. Blood pressure should be checked for everybody. MRI depends on the findings. And we can help them a lot. It's not that you do a diagnosis of papilledema with the tumor. You will have to follow them up. You need to prognosticate depending upon what stage of papilledema they are in. And you need to do serial fields, and you are almost a deciding factor in stopping medication for benign intracranial lesion or even a tumor. So this way we have a role in diagnosis as well as prognostication as well as following them up. So as you know that this is the flow of CSF around the brain, which is a protective thing, but at any stage there can be blockage and that can lead to swelling of the optic nerve. Because of these reasons, either it can be pressure or obstruction of orthograde axoplasmic flow, which comes as an optic disc swelling. And it may not be always bilateral. We can always pick up a frank case, but being an ophthalmologist, we should pick up very early stage so that neurologists can make their decision depending upon your diagnosis. I'm not going into the theories. This is basically I mentioned for resident here. These are the three theories for the optic disc swelling. So if you look at the etiology, it's like any cause for intracranial pressure, either it's a production or decreased flow or increased brain volume due to abscess or hemorrhage or decreased drainage sometimes because of hydrocephalus or meningitis. And choroidal plexus tumors are very rare, but it can happen. And this is the most important, as Nikhil said, you need to diagnose whether it is a pseudo or a true disc edema. Once you found out that it's true disc edema, you need to rule out whether it is a papilledema. It's actually a misnomer. Disc edema in both eyes, it's called papilledema. Papilledema is most commonly, according to textbooks, it's because of the tumor or any cause due to increased intracranial tension. So then, put that malignant hypertension somewhere. I feel it's mandatory that in any case of papilledema, even if you don't see chronic arterial attenuation or chronic hypertensive retinopathy, still it should be the first test which should be done. Even in youngsters, we are seeing malignant hypertension at the age of 12 years, 14 years. Even the routine systemic hypertension nowadays, you can see it starts at 25 or 30. So as we are seeing more and more NaON in young, we are seeing more of malignant hypertension in young patients. So I would say that's the first thing, and then you have to decide whether if it is papilledema, you have to do a neuroimaging. You have to decide which neuroimaging, because with one imaging you should get all the imaging, all the information ideally. Either it's intracranial mass or any other problems. Signs-wise, early stages of papilledema will not come to you with any ophthalmic signs. That's why they will have headache or tinnitus. They will usually go to a neurologist. Then neurologist will send it to you. But if they are at the end stage, burnt out stage, they will come to you because optic nerve is involved. So there are mechanical signs, as Nikhil has explained. These are the 5 mechanical signs, and there are 5 vascular signs in any edema. This is basically to rule out whether it is true or pseudo. So this is the classification. This slide is mainly for residents here, so that you can really, you should know these things by heart so that you can apply to this patients. So in addition, I think along with being an ophthalmologist, you should be doing a basic neurological examination, which this papilledema starts at MBBS level, it goes on to PG level and even at fellowship level, but we still make lot of minor mistakes when you handle a case. So basic knowledge of cranial nerve examination you should have, especially to look at this wrinkling, as well as pick up this facial nerve palsy. They are all simple, and also with simple examination you can even check for corneal sensation and things like that. And ocular motility is a part of papilledema evaluation. If you take a patient as a whole, it gives a lot of information to you. Where if there is a abduction limitation with papilledema, you know for sure that there is something going on at the brain level. So this is one thing I wanted to show. You can in fact induce this the venous pulsation if it is not there. This case you can see that there is pulsation there, but sometimes putting a little bit of pressure on the sclera you can, but it doesn't mean that its absence. Sure shot you can say that there is a papilledema due to intracranial hypertension or not. It may not be always. So last sentence here, clinical sign needs to be interpreted in the light of history and other ocular clinical findings. So you can't go with only one sign here, so you need to look at other things as well. So this was I was talking about. First two stages probably will go to neurologist, and second two stages most often they will come to us ophthalmologist also, but we should be able to diagnose at every level. This is, I wouldn't say it's early, it's kind of established. We don't have a specific sign to say that this is established or early, but even a subtle edema you should be able to pick up. And this is a bilateral case with again neurologist referred. He has a poor vision due to RP. You can see that retinal pigment epithelium is not healthy there. And obviously you can see this lumpy bumpy appearance. This one sign tells you that go for this. Just with one picture you know the diagnosis is very sure. Most of this exposed drusen you don't have to do a ultrasound B scan. You can just pick up why. Autofluorescence. Autofluorescence plays a very important role both in neuro-ophthalmology as well as retina practice. It's very, very cheap, but it's very important to identify these things. And this is again one more case of lumpy bumpy appearance here, and see how autofluorescence picks up everything in this type of cases. And even B scan, somebody said this can be done to notice. You can see this. This technique has to be accurate, especially with the angle, especially if you have a buried drusen. You can diagnose easily the exposed drusen with autofluorescence. If it is buried, you need to go with that 30-degree angle so that we can pick up. So this is common to every optic nerve dysfunction. You have to do visual acuity. Pupil evaluation, as all of you know, it's the most important vital thing. It's like cardiologist checking your pulse. That's the same way checking pupil should be a reflex for all of you. And the color vision, brightness and contrast sensitivity, confrontation test along with visual field test. These are a must to know the optic nerve function. With regards to neuroimaging, whether to do a CT, MRI or other things, it depends upon case-to-case basis. Ideally, if you want to rule out anything in the brain, it's best to do MRI with contrast. And if you have a suspicion, it's best to do MRV at the same time. We don't have to inject anything different for MRV. It just with the change, they can do it. So this is the visual field. And OCT helps, as Dr. Satyakarna has shown some of the cases there. And hypertensive retinopathy, I'm not going into the detail. And magnetic resonance image, if it is normal, then you'll have to do other things. So some of the cases will be very, very straightforward like this. You don't have to check with anything else. And sometimes if the MRI is normal, then you can't send the patient again to, back to the radiologist, do MRV now. It's better that if you do it at the same time. So this is not so straightforward, but sometimes it will be very straightforward. By looking at the patient, mushrooming of that optic disc tells you that it's more of a BICH. They are complaining of headache. They are obese patients, so it's easy. But this decision is not easy. That's why I would suggest ideally MRI contrast with MRI for everybody. Or at least you can write a note that if after few cuts, if the radiologists don't see any tumors, you have to go ahead and ask them, they're saying that go ahead with contrast as well as MRV at the same time. because this we have to write to them. Otherwise, there'll be most of the times technicians sitting there. There'll not be radiologists sitting there most often, and most often they are doing now online reporting. Online report you get. So this is very important in your prescription. And this is the second most important mistake. Most of the neurologists also do it, unfortunately. When you send for lumbar puncture to know the opening pressure, they just do a CSF analysis and send them back. I would say we have to do both together to rule out any kind of other pathology. Most importantly, from idiopathic intracranial hypertension point of view, CSF opening pressure is the most important treatment, investigation. With regards to treatment, I don't think so there is any role of steroids unless there is an acute significant visual loss in papilledema, as earlier we discussed, except in that kind of cases. Otherwise, most of the BICH, if it is diagnosed early, with the visual field we can monitor and we don't have to go into any kind of surgical treatment. But it just because of this negligence at every level, they can go into blindness. It's possible that they will lose lot of their visual fields, lot of their visual acuity. So here I think there is a major role of ophthalmologist as well as neurologist in this particular situation, where we can avoid these kind of unpredictable procedures, which we have to do it if it is inevitable. But as an advocate of these patients, we have to prevent these things. I will just end with this case showing this girl comes to you with, you can see she's not so obese. She has this esotropia, double vision. Obviously she has bilateral abduction limitation, you can see on both sides. And she has this. It's not a very severe papilledema. I would say early to established papilledema here. This is the enlarged view. You can even see that cup is not full completely. It's getting filled up over a period of time. As the pressure is rising, pressure is building up in the brain. This flow is obstructing, and slowly you can see that retinal nerve fiber layer is getting filled up. It's more in the left eye compared to right eye. We do this case, there will be always a dilemma whether I should do an MRI or a contrast or MRV. I would say that we have to do everything, but it can be a tumor. We don't know unless you do the imaging. You don't know. Some people might say that I will do a CT scan. Of course, it's fine, but what happens if the CT scan becomes normal? We might miss the sagittal sinus venous thrombosis here. It may be 1 in 10, but it's most important for that patient. So I would even send them back. We are assured that there is no tumor, but we are still not sure about the cause of this problem here. So this is one of the history taking for BICH patients. Whatever I have written in yellow are some of the most common ones, what is used by young patients, most of them, especially for acne. And these are the other systemic associations. So anemia plays a very important role. Most of the patients are anemic, so it's very important to get their basic hemoglobin done. And this is, I'm not going into the details of this, pediatric versus adult. And this is the first choice of treatment, acetazolamide. You can go up to 750 mg to almost 2 grams, depending upon the amount of pressure as well as signs what you see. Steroids, in very rare cases of sudden visual loss with the presence of inflammation, you can give intravenous methylprednisolone. Repeated lumbar punctures, not really so, is a treatment of choice. And when there is deteriorating visual function, severe incapacitating headaches, then you can do. If there is more of a visual loss, you can do optic nerve fenestration, which is still debatable, but that's kind of rule of thumb. If there is more of visual loss, ONSD. If more of headache, probably a VP shunt is a good idea. So this is one of the cartoons showing that. So this girl took just acetazolamide and she was put on 1 gram. We saw her within 7 days. We saw her within 15 days. She was improving. If she is not improving at 7 days, you might have to increase the dosage and then call after again 3 days or 4 days. And then this is her optic disc, and her fields also, she had central scotoma which resolved over a period of time. So you can see she's almost having 0.4 to 0.5 CD ratio, which was filled up before. So in summary, I would say papilledema is a sign of systemic disease. It can be tumor or anything else. Always rule out any kind of ocular disease, as simple as Ocular syndrome to malignant hypertension. Imaging, you have to be very careful when you prescribe an imaging for them, and it's always a transdisciplinary approach, and it's a life-saving intervention in many ways. Thank you very much.